Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. Yesterday, I told some diseases causing intestinal obstruction. Let us complete the topic of intestinal obstruction today. So now we are talking about the intestinal obstruction in adults. We have completed the topic of adhesions and bands. The next cause for intestinal obstruction is internal herniation. What is hernia? Define hernia. Define hernia. Okay, abnormal protrusion of viscus. It is only part of the answer. Please complete. Having its own sac, that's okay. But what the definition? The definition of hernia is abnormal protrusion of a viscus in a cavity through a normal or an abnormal opening. That is hernia. If this protrusion occurs externally, we call this as external hernia. If the protrusion occurs in the cavity itself through a normal or abnormal opening, we call that as internal hernia. So now we are talking about internal hernia. That means protrusion of the abdominal viscera through a opening, either normal or abnormal, into another cavity or another space. The sites of internal herniation. There are some defects in the perineal cavity. So those defects will be the sites for the herniation. Number one is the foramen of Winslow, a hole in the mesentery, a hole in the transverse colon, a hole in the transverse mesocolon, then defects in the broad ligament of the uterus, then congenital or acquired diaphragmatic hernia. So these things, they cause the herniation. You can see here, this is the foramen of Winslow. So this is the upper part of the duodenum, this is the porta hepatis. So between that, we have the free body of lesser momentum. So behind the free body of lesser momentum is the foramen of Winslow. Now you can see the bowels have protruded into that. So the bowels have protruded into the lesser sac. So the proximal part of the bowel has distended enormously, you can see here. And this is a closed loop obstruction. So the closed loop also dilates, the proximal loop also dilates. This is a hole in the mesentery. You can see the bowel has protruded and actually it has become even gangrenous. This is a hole in the transverse mesocolon. So when you do gastrojejunostomy operation and fail to suture the transverse mesocolon rent to the wall of the stomach, this can happen like this. And this is the opening in the broad ligament. So normally, broad ligament has no opening. So by any reason, if some opening develops here, then that can be the site for herniation. Then other sites of internal herniation being the retroperitoneal foci. There is a duodenal retroperitoneal foci. There is left paraduodenal, right paraduodenal, then cecal retroperitoneal foci, superior, inferior, and retrocecal. So there are certain fossa in the peritoneal cavity. So these are the foci. So these foci can be the sites for internal herniation. Then intersigmoid fossa. These are the foci around the duodenojejunal junction. You can see the fourth part of the duodenum, which is retroperitoneal, is continuing as the jejunum, and this is the duodenojejunal junction. So a retroperitoneal organ is becoming intraperitoneal. So while it is becoming intraperitoneal, then at the sides of that particular viscus, you will see some foci. So you can see the paraduodenal foci and duodenojejunal foci. So this is a superior duodenal foci, and this is the inferior duodenal fossa. And the third one is the paraduodenal fossa. It is only one opening here. There is a space above, space to the left, space to the bottom. So into this space, under the fold of this peritoneum, a bowel loop can protrude and can get herniated. And it may be obstructed. So what you should know here is, whenever there is protrusion, yes, these foci are present normally. These are not abnormal foci. These are normal foci. But the opening will be very small. Just they will be very shallow also. They are not very deep, just shallow. That's why bowel can't even enter there. Just it will be like this much shallowness, that's all. If they are more shallow, more hollow, with a small opening, then that becomes the fossa for herniation. Otherwise, in a normal case, there doesn't exist much space. It will be a wide, shallow space. So the thing what you have to remember or see here is the edge of the fossa, the mouth of the fossa. At the mouth, see whether there are any blood vessels or not. You can see here the paraduodenal fossa is having the inferior mesenteric artery vessel. The inferior mesenteric vein is running in its border. So when herniation occurs here, to relieve the herniation, you may cut this border. Then there will be damage to the inferior mesenteric vein and artery. Hence, you must always be careful before making an incision into the margin of the mouth. These are the foci around the ileocecal junction. This is superior ileocecal. The normal, there will be only just a fold of peritoneum with small, shallow fossa here. Sometimes it gets deepened, and into the deepened fossa, there may be herniation. That too, when the mouth is narrow. There is one more, that is inferior ileocecal fossa. Another thing is behind the cecum. So sometimes cecum is peritonealized completely. On the posterior side also, there will be peritoneum. So then there will be a fossa behind the cecum also. Preoperative diagnosis is impossible. The patient presents only with the features of intestinal obstruction. You can't make the cause for that. So because the obstruction is not relieved by conservative management, you go for surgery. In this, when you do laparotomy on exploration, you will find the bowel entering into one of the foci. Treatment, laparotomy, and release of the constricting agent. So what is the constricting agent? The mouth of the fossa. Or if an opening is there, like foramen of Winslow is there, the opening itself is the constricting agent. So what you should do? You must cut the constricting agent. When you cut the constricting agent, you must make sure that there are no important structures there in the opening. So sometimes major blood vessels run in the edge of the constricting ring. Example, foramen of Winslow. Foramen of Winslow, what important structures are there? What important structures are there in the edge of the foramen of Winslow? Yes, very good. It has hepatic artery, portal vein, and the bile duct. That is the portal triad. So portal triad structures are there in the margin of the foramen of Winslow. That's why you must be very careful. Then defects in the mesentery. They have the mesenteric blood vessels or superior mesenteric vessel. The paraduodenal and duodenal fossae, they have the inferior mesenteric vessels. In these cases, the constricting should not be cut. So please remember, for these three defects, you should not cut the constricting ring. How to reduce the herniated bowel? The distended loop in such circumstances must first be decompressed and then reduce. So what you do is you open the fossa, bowel, you make a opening in the bowel, and then without spilling any contents out, you aspirate the contents. For that, what you do is first you make a pursing stitch, and in the pursing stitch middle, you make a small opening. Into that, you push a catheter and suck the contents out. Once you suck the contents out, you tighten the pursing stitch and take away the catheter. So then there will be no spillage of the contents. So once the bowels get deflated, then of course it will be very easy to retrieve them. So that is about the internal herniation. Then stricture of the bowels. So the other cause for obstruction in adults is stricture of the bowels. The cause being tuberculosis, Crohn's disease, malignant strictures. Malignant strictures can be due to carcinoma, lymphoma, and sarcoma, also called like the GIST tumors. Then stricture can also be due to post-operative following intestinal anastomosis. If you have not fashioned the stoma properly, so there may be narrowing at the site of the stoma. Clinical presentation, they present as subacute or chronic intestinal obstruction. Management, strictureplasty. What is strictureplasty? What is strictureplasty? What is strictureplasty? Very good. Incise in the axis of the bowel and sutured perpendicular to the axis of the bowel. So that is how you do widening of the stricture. If there is a long tubular stricture, you can do resection of the stricture followed by end-to-end anastomosis. and wide resection in case of malignant strictures. So this is a case of stricture of the bowel. So an incision is made in the axis of the bowel. So the stricture is incised. Then in the middle of the incision, you apply two stay sutures, one stay suture above, another stay suture below, and pull them apart. Once you pull them apart, a horizontal opening will become a vertical opening. Once it becomes vertical, then you suture it in two layers, an inner alcoat and outer pseudomuscular. This is how you do strictureplasty. So this is the strictureplasty to widen the place of stricture. So this is done only for inflammatory strictures like tuberculosis and Crohn's disease. For a carcinoma stricture or carcinoid stricture or GIST tumor or lymphoma, you must do wide resection. At least 2.5 centimeters of bowel on either side of the stricture must be included in the resection segment and followed by an end-to-end anastomosis. Next is the bolus obstruction. Next cause is bolus obstruction. The bolus obstruction can be due to food. Already we have seen this in case of gastrojejunostomy, unmasticated fiber food or fruits. Then bolus can be due to gallstones, trichobezoar, phytobezoar, stercoliths, and worms. Gallstone obturation pathology. These occur due to cholecystoduodenal fistula. So whenever there is fistulous communication between the gallbladder and duodenum, a large stone can pass through this fistulous opening into the duodenum. The impaction occurs usually at 60 centimeters proximal to the ileocecal junction. There will be recurrent attacks of subacute obstruction due to incomplete or a ball valve effect. Already I told you about this ball valve effect. The gallstone obstructs. Because it is spherical, it then slips back into the dilated proximal segment. The obstruction is relieved. Then again it comes down and blocks the narrowest part, that is obstruction. So such recurrent acute obstructions or subacute obstructions will be there in case of gallstone obturation. Plain X-ray abdomen, that will show you evidence of small bowel obstruction, aid in the biliary tree, and stone may or may not be visible. Because how many gallstones are radiopaque? Give me the percentage. How many gallstones are visible on plain X-ray? Yes, they are around 20%, that is 15 to 20%. They are visible, so they are radiopaque. So you can see here a radiopaque density with the jejunal and ileal shadows, and you can see the air in the bile duct. Treatment: laparotomy plus enterotomy. That means first you do laparotomy to open the abdominal cavity, then you open the small bowel to take out the gallstone. The region of the gallbladder should not be explored for fear of breaking opening the fistula between the gallbladder and duodenum with associated bile leak. So the treatment is simple. You just make an opening in the intestine and take out the gallstone. But here what you should do is you should not make an incision at the site of impaction, because wherever the gallstone got impacted, at the site there will be some ulceration. So if you make an opening there, you are making an opening through the ulcer. So the healing will be impaired. So what you should do is you must make an opening more proximally, in the proximal part of the bowel. And you have to knead the stone more proximally, just by milking it. Then you take out the stone. So not only here, anywhere, whenever you want to remove a stone from a duct or a tubular structure, don't make the incision directly on the stone. You make the incision more proximally, and through that opening, you deliver the stone out. So other places, the ureter. Whenever you want to do ureterolithotomy operation, that ureterolithotomy means removal of the ureteric stone by making a opening in the ureter. So there also you follow the same principle. The next condition is the trichobezoars and phytobezoars. These are form mass of hair balls and undigested fruit or vegetable fiber, respectively. So this presents like a subacute or acute intestinal obstruction. You open the abdomen, you will find a mass in the intestine. So you try to knead the mass into the cecum, because from external side you can break the mass, and that can be just pushed down into the cecum. Otherwise, you have to remove it by open removal. Volvulus. It is twisting or axial rotation of a portion of the bowel. When complete, it forms a closed loop obstruction with ischemia. If it is off twist, it may produce just subacute obstruction. But if it turns completely 180 degrees, then it produces a total obstruction of this particular loop. So this loop now is a closed loop, because the efferent limb and efferent limb both are completely occluded. So what are the dangers of closed loop obstruction? What are the dangers of closed loop obstruction? Okay, apart from ischemia and gangrene, what are the other side complications or effects of the closed loop obstruction? Closed loop obstruction will have enormous distension. This distension can cause the ischemia of the bowel. The ischemic bowel may perforate, and that may produce peritonitis. So the initial complication of volvulus is enormous distension. How volvulus occurs for a bowel loop? So these predetermined factors must be there. Number one, for the loop, at base, if the base is narrow, so narrow attachment of the base of the bowel loop. A long loop of bowel, overloaded bowel. And fourth factor is band of adhesions at the apex of the bowel loop. So if any one of these are present, they can cause the volvulus. Volvulus of the small intestine. In neonates, it presents like the volvulus of midgut. In adults, it usually occurs in the lower ileum. Causes in the adults, primary or idiopathic. In Africans, particularly following consumption of a large volume of vegetable matter. So that vegetable matter causes distension of the lower ileal loops, because they contain a lot of fiber. So they become a big mass like in the lower ileum. The lower ileal loop, sometimes for some people, they hang down even into the pelvis because of a long mesentery. So a loop of ileum can undergo volvulus when it is especially loaded. Then secondary, following additions to the parietes are uterus and fallopian tubes. For example, if a loop of bowel is adherent to the uterus, then that becomes a axial point. Over that point, the bowel will undergo torsion. So for example, this is this wire is the bowel loop. If it gets fixed at one point, then it can rotate. So when it rotates, it becomes the volvulus. So additions to the parietes are uterus and fallopian tubes. Treatment, reduction of the twist and managing the underlying cause. So untwist it, and if any addition is there, utilize the addition. Then cecal volvulus. Normally, is cecum adherent to the posterior abdominal wall or not? Cecum, is it adherent to the posterior abdominal wall or not? That means, is it retroperitoneal or intraperitoneal? Yes, you are all right. Cecum is retroperitoneal structure, but the most proximal part of it has a covering of peritoneum. That is why there is a retrocecal fossa. So there will be tinea coli here. This bit of the cecum will be normally having a posterior covering. But sometimes what happens, the whole of the cecum and descending colon may have a mesentery. We have seen in the yesterday's class, if there is some anomaly in the rotation of the gut, that is in third stage, there will be a floating ascending colon, floating descending colon. And the complication of floating ascending colon is volvulus. So this volvulus occurs for the cecum now like this. So when it gets peritoneum and completely all around with a mesentery, then it can undergo torsion. That is volvulus. So it may occur as a part of volvulus neonatorum or de novo. That by itself it can undergo. It twists clockwise. On examination, there is palpable tympanic swelling in the midline or left side of the abdomen. Once it got twisted, it is not in the right iliac fossa. It moves to the left of the abdomen or slightly in the midline. Investigation, plain X-ray of the abdomen. It shows this type of shape. Some people describe this as a kidney-shaped air shadow. Some people describe this as fetus, shadow like a fetus that in embryonic stage. So that's why it is called embryo shadow. So ileal loops and occasionally a distended cecum in the center of the abdomen. You can see here the ileal loops. Barium enema shows absence of barium in the cecum. So you can see here the central shadow. This is the cecal shadow. This is like a fetus. That's why this is called the embryo sign. Treatment, surgery, there is reduction of the valvulus and fixation of the cecum to the right leg fossa, and or a cecostomy. Cecostomy means you make a opening in the cecum and leave a tube inside it and get the tube out onto the skin. So what is the purpose of doing cecostomy here? Whenever there is volvulus for the cecum is greatly distended. It may have threatened rupture. Even if you do untwisting, sometimes the distance won't be relieved. So when the distension is so perplexingly high, it may lead to perforation. That is why what you do is you do a cecostomy. You make an opening deliberately and make an opening in the skin. So through the skin, you pass a tube into the cecal opening into the cecum and drain the cecum out. So cecum gets deflated and chance of perforation will be avoided. Number two, whenever you do cecostomy, the cecum of course gets adhered to the abdominal wall. So it becomes cecopexy. Pexy means fixation. So when cecum gets adherent to the abdominal wall means there is cecopexy. So instead of suturing the cecum to the abdominal wall, if you put a Foley's catheter in the cecum and pull it, so the cecum gets stuck to the abdominal wall. So that is how cecopexy can happen. If the cecum is ischemic or gangrenous, a right hemicolectomy is done. Volvulus of the sigmoid. This is again an important topic. So this is given frequently in the examination as a short notes. It is rotation of sigmoid occurring in anti-clockwise direction. What is the direction of cecal volvulus? Cecal volvulus is in clockwise direction. Sigmoid volvulus is in anti-clockwise direction. You can remember cecum clockwise, C for C. And the opposite side will be turning to the opposite side. Opposite side of the cecum is the sigmoid, and it turns to the opposite direction. Incidence, it is rare in Europe and USA, but more common in Eastern Africa, Eastern Europe, Africa, and India, where the people are habituated to take a lot of fiber as well as fruits. So because of the lot of fiber in the vegetables, the patient will be passing bulk of stools, so large bulk. So whenever large bulk is there means sigmoid is usually loaded. So a loaded bowel is always predisposed for volvulus. So the predisposing factors is high residue diet and chronic constipation. So it rotates in the anti-clockwise direction. So the predisposing factors, narrow attachment of the pelvic colon. So base of the pelvic colon is narrow. Long pelvic colon. Overloaded pelvic colon. Sometimes there may be band or additions between the apex of the pelvic colon to the abdominal wall due to diverticulitis. Clinical features, there will be features of large bowel obstruction, namely constipation, acute lower abdominal colicky pain. Central abdominal distension is an early and progressive sign. Later, there is peripheral distension. What is the cause for this central abdominal distension? Why? The center of the abdomen is very much distended. What is the cause for that? What is the cause? Now the central distension is because of the sigmoid. So whenever there is valueless, there is closed loop obstruction. Because of the closed loop obstruction, the sigmoid distends enormously, and sigmoid occupies center of the abdomen. So there is central abdominal distension. Later, peripheral distension. Peripheral distension means to the flanks. Why this peripheral distension? That means the proximal part of the bowel. That means proximal to the obstruction. That means the descending colon, transverse colon, and ascending colon, they distend. So first there is central distension due to distension of the sigmoid loop. Later there is peripheral distension due to the colonic distension. Vomiting occurs late and denotes bad prognosis. So this appears like a coffee seed. This is the coffee seed. Probably you might have not seen this coffee seed. That's why I put the image of the coffee seed here. So this is exactly looks like a coffee seed. That is called coffee bean or coffee seed appearance. So massive colonic distension, dilated sigma-shaped loop of bubble running diagonally across the abdomen with two fluid levels, one in each loop. This is described as the coffee seed appearance. Treatment, the non-operative method, untwisting the twist by flexible sigmoidoscopy or by rigid sigmoidoscopy. So you can try a sigmoidoscope passed into the rectum per anus. If you can negotiate, this is possible only in not full turn sigmoid volvulus. If it is half turn or 3/4 turn is there, then you may be able to negotiate it into the efferent loop and then turn it clockwise. So the sigmoidoscope is passed into the efferent loop, and if it is turned clockwise, then you can derotate it. But the endoscopist must be very cautious, because once the bowel is derotated, lot of flatus and feces will come out with lot of force. So that will spoil the whole room. That is why the endoscopist should wear proper personal protection equipment. Otherwise, he will be spoiled with the fecal matter and the foul smell of the flatus. So untwisting the twist by flexible sigmoidoscopy or by rigid sigmoidoscopy. So you can see here, a sigmoidoscope is passed and it is now rotated clockwise. Surgical management, laparotomy with untwisting of the loop and perianal decompression. So you do laparotomy, hold the sigmoid volvulus and derotate it in the clockwise fashion, but the sigmoid loop will be very much distended. In the cecum, what we have done, we did the cecostomy. In the sigmoid, instead of doing sigmoidostomy, what you can do is you can pass a tube per annum into the dilated sigmoid loop, and once you squeeze the sigmoid loop, all the air gets expressed out. So that is how you can decompress the sigmoid loop. When the bowel is viable, fixation of the sigmoid loop to the posterior abdominal wall is done. If you don't fix the sigmoid loop, then again it may undergo valvulus. So to prevent that one, what you do is you apply few interrupted sutures to the sigmoid loop to the posterior abdominal wall. If the conditions are favorable and patient is fit, you can do resection and anastomosis. That means you can resect a large loop of sigmoid and do the anastomosis. But it is an emergency. Bowel is unprepared. That is why this particular resection anastomosis should not be taken easily. This should be done by a very well experienced colonic surgeon. Otherwise, there will be failure of our anastomosis and there will be a lot of complications. So the safest method is to derotate the valvulus sigmoid and then fix the sigmoid to the posterior abdominal wall. If there is an experienced colonic surgeon is there, patient is in fit condition, then if the viable bowel is there, they can do resection anastomosis. If there is impending gangrene or gangrene, we have to remove that. Then how we remove that one? You can remove it by Paul Miklik's procedure or by Hartmann's procedure. What is meant by Paul Miklik's procedure? What is the other name for Paul Miklik's operation? Paul Miklik's operation is one of the frequently given question in the theory examination. What is Paul Miklik's procedure? Okay. Paul Miklik's procedure is nothing but, it is also called as the, okay, that is how you do it. Okay, Paul Miklik's procedure is nothing but a double-barreled colostomy. In simple words, you make the two loops, efferent loop and efferent loop of the bowels side by side and join them together by seromuscular suturing. Excise the bowel after keeping it outside. So that is Paul Miklik's operation. So the advantage of this operation is you can undo the colostomy by not opening the abdomen later, just with the help of enterotome, that means a crushing clamp. So with the help of a crushing clamp, you can undo this colostomy and make the passages again continuous. Hartmann's operation. What is Hartmann's operation? This is also another important question in the theory examination. What is Hartmann's procedure? What is Hartmann's operation? Yeah, I told you in the previous class also about Hartmann's operation. Okay, then I will tell you. Hartmann's operation means now this is the descending colon, this is the sigmoid colon, and here is the rectum. So this is the descending colon going into the rectum. Now you want to remove the sigmoid colon because there is valvulus and gangrene. Or if there is a large tumor is here, you want to remove this tumor. So what you do, you cut the sigmoid here, you transect the sigmoid here. So remove this bit of sigmoid, excise. So you are doing sigmoidectomy. So after sigmoidectomy, what you want to do, continuity to be established. If you can establish the continuity is okay. If you cannot make the continuity established, what you should do, you should provide drainage. So if the bowel is well prepared, you can do the anastomosis between the descending colon and rectum. It is not an elective case. If it is an emergency case, then what you do, you just bring the descending colon out and make it into a colostomy. So excision of the sigmoid colon followed by descending colostomy is called as the Hartmann's operation. This is a very, very, very important and useful operation done in many of the sigmoid colon conditions. So wherever you want to remove the sigmoid, you just remove it and do colostomy, descending colostomy. So this can be done as an acute procedure or emergency procedure for acute intestinal obstruction due to sigmoid tumors or sigmoid masses or due to volvulus of the sigmoid with gangrene. So you can excise the segment and do descending colostomy. Then what about the rectum? Either you can suture this one or you can bring this end also outside. You can get outside and make it into an opening. This becomes mucous fistula. Especially this is done in case of ulcerative colitis. Whenever there is rectal inflammation, severe rectal inflammation, if you suture it, the sutures may break open later. That's why I just keep it outside as a mucous fistula. And this is as colostomy. So of course, Hartmann's operation means descending colostomy with sigmoid colectomy and rectal stump suturing. That is Hartmann's operation. I think you got this answer. So please remember this. This is very important procedure and many a times it is asked in the theory examination, Hartmann's operation. Actually, we have discussed about this in the management of colon obstruction as well as the management of tumors of the colon, neoplasms of the colon. There also we have discussed about this Hartmann's operation. Or you can do primary sigmoid colectomy followed by anastomosis. Anastomosis descending colon to the rectum. This is feasible, as I said already, only in well-experienced colonic surgeons because the bowel is unprepared. So when you are doing it, means there is a risk of perforation or leakage. So you can see this is the volvulus of the sigmoid. So whenever sigmoid distends, it will distend to such a large size, to such big, enormous size. Yes, there is a doubt from one of our students because it's distended and you pass a tube and then deflate it. So even though you deflate it, distance will come down, but the walls have been stretched out and became thin. So such thin walls, is there any difficulty to suture them to the posterior abdominal wall? There is no difficulty. Once they get deflated, you can make out the tinea coli, the bands of the tinea coli. So you can take the bite from the tinea coli site. Just 3 or 4 stitches will be sufficient. Of course, it should not go more deep into the wall of the bowel. So this is the Hartmann's operation. Descending colon is brought out as colostomy, rectum is closed, stump is closed, sigmoid is removed. This is the Paul Michel's anastomosis. The sigmoid, the colon is brought out as 2 limbs and sutured together. This is called double barrel. Then the sigmoid volvulus is excised, keeping it outside. So there will be 2 openings. So this is how you do it. So take the loop, bring the loop out and fashion it into double barreling. Then you resect the sigmoid. So the sigmoid loop is resected here. The wound is closed. Then you put the enterotome to crush the spur between the 2 limbs gradually. Once it gets crushed, then you make a skin incision around the colostomy site. The margins are trimmed for the colostomy, and it is sutured. It's pushed inside. Skin opening is closed. Opening in the skin, this opening is closed. Once the bowel is pushed inside, the wound is closed in layers. So this is how you finish off closing in the colostomy. So the Paul McLean's operation is a simple operation and very useful operation. Then there is a condition called compound volvulus. This is called iliosigmoid knotting. So when the volvulus loop of the sigmoid is rotating, it takes the small bowel loops also along with it. Then it is called compound volvulus. It is rare. It is twisting of the ileum around the sigmoid column, resulting in gangrene of both segments of the bowel. X-ray abdomen. Distended ileal loops with distended sigmoid loop will be seen here. Surgery is the same principles. First of all, derotate it, then decompress it, do resection anastomosis. So whatever that is possible there, depending upon the patient's general condition and fitness, you do the procedure. So there is about intestinal obstruction in the adults, then intestinal obstruction in the elderly group. The obstruction usually manifests as chronic or acute and chronic obstruction. The causes for chronic intestinal obstruction: organic causes, intraluminal, fecal impaction. Already I told you, fecal impaction is one of the common causes of obstruction in very old people who are bedridden, or sedentary people, or sick people who are not getting out of their beds. So in those conditions, for example, a patient with hemiplegia is there, he is confined to the bed, then there will be fecal impaction. Then intramural causes within the wall: colon cancer, diverticulitis. Why diverticulitis will have obstruction? Diverticular outside, they are inflamed outside the bowel wall. Then why should they cause obstruction? We have finished the discussion on the diverticulitis. That is why I am asking you. Yes, they cause a lot of fibrosis. Whenever diverticulitis is there, there is peridiverticular fibrosis. This there is peridiverticular fibrosis that leads to stricture of the colon. There will be stricture of the colon causing the obstruction. So the cause of chronic obstruction in diverticulitis is because of peridiverticular fibrosis and stricture of the colon, the sigmoid affected colon. Then strictures of the colon due to Crohn's disease, ischemic colitis, and tuberculosis. Then anastomotic stenosis. Extramural causes: adhesions. Adhesions usually occur for the small bowel. For the large bowel, adhesions though occur, they do not cause obstruction. Then metastatic deposits. Whenever there are a lot of peritoneal deposits due to sepsis, they can deposit over the colon, and those deposits can cause obstruction. Similarly, endometriosis. What is endometriosis? What is endometriosis? Yes, very good. Presence of endometrial tissue outside the uterine cavity. So it may be there over the serous coat of the uterus, over the fallopian tubes, over the ovaries, over the pelvic wall, in the Douglas pouch, over the sigmoid colon. So all these places they can have the endometrium. So whenever there is endometrium, it responds to the menstrual cycle. So there will be the menstrual cycle will be there, shedding and proliferation, and then congestion, and then shedding, and again, so like that will be there. So these processes will cause a lot of inflammation and fibrosis and hematoma formation. So there will be bleeding and there will be fibrosis, so that causes the obstruction. So endometriosis case is one of the very difficult cases to operate. They produce so much thick fibrosis in the pelvis. So the structures in the pelvis, they are completely plastered to one another. You can't make all the structures. There will be a complete thick fibrous sheet. So such a difficult, then it will be very difficult to dissect the structures there. So these are all the organic causes of obstruction. Intramural, within the lumen, outside the wall. Then functional causes. That means there is no organic obstruction, but there will be obstruction. That means what obstruction is not a block. I told you already. Obstruction means it is not a block. Define intestinal obstruction. Tell me the definition. Definition for intestinal obstruction. Yes, it is lack of transit. Lack of transit of intestinal contents is called the intestinal obstruction. Functional means there is lack of transit without any block. So this can be due to Hirschsprung's disease or due to a condition called pseudo-obstruction. Clinical features. Constipation appears first. It is initially relative and then afterwards absolute. In the chronic intestinal obstruction, the features are: first there will be relative constipation, later there will be absolute constipation. Peripheral distension with great distension in the cecum. Later pain. Vomiting is a very late feature. Distal rectal examination may show a tumor or impacted fecal matter in the rectum. Plain X-ray abdomen will show gas shadows in the colon. And there will be prominent cecal shadow. Water-soluble contrast enema will show you it may show the apple core appearance due to carcinoma. Treatment depends upon the underlying cause. Already we have discussed about the management of colon cancer with intestinal obstruction. So anyway, for completion's sake, just let us review. Organic obstruction colon management. Right colon, acute on chronic obstruction. A fit patient, tumor is resectable. Quickly give me the answer. What do you do? So what about others? Only two have responded. What about others? Please respond. No, if gangrene is not there, just obstruction. Even obstruction also, you should relieve obstruction. After doing right hemicolectomy, you can go ahead and do ileotransverse colostomy because it is a fit patient. If the patient is not fit, then you can think of ileostomy. When the patient is fit, there is no problem. You can do the ileotransverse colon anastomosis because in case of right colon obstruction, the one that is dilated, proximal dilated segment is the ileum. Ileum has a complete serous coat, has a thick wall, and it has no solid fecal matter. That is why ileum can be safely anastomosed to the colon. So don't say ileostomy. You can do ileotransverse colostomy. Right hemicolectomy followed by ileotransverse colostomy. Right colon tumor, acute and chronic obstruction. Patient is either unfit or tumor is inoperable. What you do? Yes, if the patient is very sick and moribund, we can do ileostomy. If the patient is not so much sick, if you can tolerate, you can do ileotransverse anastomosis. And one of our students has asked, if obstruction is present, why can't we remove the obstruction or remove the contents and anastomose? If it is due to a bezoar or a foreign body or fecal impaction, then usually for colon, if intraluminal obstructions can be relieved by colon washes, you need not do surgery for intraluminal things which are blocking. So what is the common cause for intraluminal obstruction of the colon? It is impacted fecal matter. So you instill glycerin for 3 or 4 days, the stools get softened, then you give a bowel wash or enema, then the fecal matter will come out and it relieves the obstruction. So if there is an organic obstruction in the colon, means it is either due to carcinoma or it is due to tubercular stricture or Crohn's disease, or in Western countries, diverticulitis with diverticular mass. So these are the causes for the mass in the colon. So here you can't take away something from the lumen. You have to remove the mass along with the involved structure. So in the cecum, if you just remove the cecum and do the anastomosis, you are doing anastomosis between the ileum and ascending colon. Ascending colon has no total serous coat. So the bowel parts which has no complete serous investment or peritoneal investment are not suitable for anastomosis. That is why you choose the transverse colon. So you do right hemicolectomy followed by ileotransverse colostomy. If it is inoperable case or patient is very unfit, you do ileostomy or ileotransverse colostomy. And once the patient is fit, then once the patient becomes fit, you can do right hemicolectomy later. Then organic obstruction in the left side of the colon, this is the descending colon, acute and chronic obstruction, fit patient with resectable tumor. Patient is fit and tumor is operable. So what do? It is acute obstruction and it is unprepared colon. What do? Bowel is unprepared. Proximal part of the bowel is very much distended, contains lot of solid fecal matter, contains lot of bacterial proliferation. So can you do anastomosis? So then what you do? So if you can't do colectomy and anastomosis, what you do? Hartmann's operation is done for the only sigmoid cases because you can do sigmoidectomy. For descending colon, you don't do any Hartmann's operation. So you have two options here or three options here. As many of you have said, you can go ahead with proximal colostomy. That means you can put a opening you can bring the transverse colon outside and put an opening in the transverse colon. That is transverse colostomy. That is number one option. Number two option is just to do anastomosis between the transverse colon and pelvic colon. That is transverse pelvic colostomy without doing hemicolectomy. That is to bypass the obstruction. Once the obstruction is relieved, patient's condition improves, then do left hemicolectomy. That is what you do. So it is a fit patient with resectable tumor. Though patient is fit, though tumor is resectable, because it's unprepared bowel, you don't go for left hemicolectomy. You either do anastomosis between the pelvic colon and transverse colon, tide over the emergency, then afterwards prepare the bowel well and do the left hemicolectomy. And that is ideal procedure. If the patient is not so much fit, but here it is said that this patient is fit, you can do this procedure. If the patient is not fit, then you can do just transverse colostomy. And third option is, what is third option? Unprepared bowel, fit patient, operable tumor. So what is the third option? Unprepared bowel, fit patient, resectable tumor. Very good, very good, wonderful, very good, excellent. That is called on-table lavage, on-table colonic lavage followed by left hemicolectomy. So this is an ideal procedure, but you cannot do this. So you do a pelvic transverse colostomy or transverse colostomy. After improvement of general condition of the patient, do left hemicolectomy. Acute and chronic obstruction, unfit patient with resectable tumor sigmoid. What you do? Mass is there in the sigmoid. Patient is unfit condition. Tumor is resectable. What do you do? That's wonderful. You have given the correct answer. It is the Hartmann's operation. Hartmann's operation is nothing but it is sigmoidectomy only. So later what we do is we do the descending colon rectal anastomosis. Once the patient condition improves, you prepare the bowel and then do anastomosis between the descending colon and the rectum. So this is the Hartmann's operation. So after the improvement of general condition of the patient, reconstruction is done. If it is an inoperable tumor, for Hartmann's operation, there is no need to prepare the bowel because you are not doing any anastomosis, you are just doing colostomy. But when you want to do anastomosis, definitely the bowel has to be prepared. Nizami, what is your doubt? Am I clear, or do you have still the doubts? Okay, if it is an inoperable tumor, sigmoid, acute and chronic obstruction. After Hartmann operation, you are doing colostomy. Hartmann operation means you are removing the sigmoid along with the tumor. So now there is no tumor, no sigmoid. Descending colon is brought out as colostomy. So fecal matter is coming out through the colostomy outside. It is collected in a bag. Rectum is closed and dropped into the pelvis. So that is what is meant by Hartmann's operation. So then where is the question of this fecal contents coming out? You mean to say from the colostomy? Yes, fecal matter will be coming out through the colostomy outside permanently. But once the patient condition improves, what you do is you reopen the abdomen, cut the colostomy site, take the descending colon, you excise the colostomy site, so make the fresh margins, and then do the anastomosis between the descending colon and the rectum. Then the patient will have normal passages. So at the emergency, the patient will have the colostomy and fecal discharge through the colon to the outside. So after some time, once you do second operation, then there will be normal routing of the fecal matter. Okay, if there is a sigmoid tumor which is inoperable, where you can't remove it, then only procedure that can be done is just doing colostomy. Leave the growth there because it's obstruction. So you keep the descending colon proximally, you cut it and then keep it outside. That is colostomy. So first what you do is X-ray, plain X-ray abdomen for any patient with constipation, pain in the lower abdomen, peripheral abdominal distension. You do distal rectal examination. Then you take plain X-ray abdomen. If there is gas in the colon, then you go for contrast X-ray. That means you give water soluble contrast or barium enema. This will differentiate, this barium enema will differentiate whether it is a organic obstruction or a functional obstruction. There is a condition which just manifests like colon obstruction, but there is no obstruction there. That is called functional obstruction. That is called adynamic or functional obstruction. The dynamic obstruction can be due to a resectable growth unfit patient, inoperable growth or unfit patient, resectable growth and unfit patient. So these combinations we may see. In the first, For the right colon, you do right hemicolectomy, left colon resection after on-table lavage. For the second one, you do either bypass, colostomy, cecostomy, or ileostomy. For the third one, right colon, you do right iliotransverse colostomy. For left colon, you do Paul Michel's operation, Hartmann's operation, or simple colostomy with mucus fistula. I hope you understand these things. If you have no doubts, we will proceed to the next slide. So this completes the topic on the dynamic intestinal obstruction. Unfit patient. Yes. Why iliotransverse colostomy? The patient is unfit. Though it is acceptable growth, the patient cannot withstand surgical procedure of hemicolectomy. That is why hemicolectomy is not done because of his metabolic status, poor metabolic condition. Only iliotransverse colostomy is done. And later, once the patient's condition improves, once the obstruction is relieved, his metabolic status comes to normal within a week or two, then you go ahead and do right hemicolectomy. Am I clear, Fatima? Okay. If the patient is not fit for iliotransverse colostomy, you can do ileostomy. But one thing you have to remember is, whenever you do ileostomy, there will be profuse drainage outside. So ileostomy drains about a liter of fluid every day out. So liter of what? Intestinal contents out. They contain a lot of potassium. They contain sodium, chloride, bicarbonate. So there is loss of water and electrolytes. And there is a lot of mucus also is discharged out. That is, the protein also is lost. So ileostomy needs proper fluid electrolyte resuscitation to the patient. So though you have done surgery, you should not keep quiet. You have to maintain the patient with fluid electrolyte balance at least for 3 to 4 or 1 week. So that is problematical. If you have done iliotransverse colostomy, so all the water and electrolytes are absorbed by the colon, so no problem. So out of ileostomy and iliotransverse colostomy is always a safer procedure because post-operatively the patient's fluid electrolyte balance will be stable. Okay, first now I'll clear the doubt of Santi. Is it like this for right side tumors, iliotransverse colostomy, and as more distal the obstruction, left side colostomy is done? Okay. Right side colon tumors, when the patient is unfit, we are just doing a bypass operation. So the safest and easily available bypass operation is iliotransverse colostomy. I think that point is clear to you. Then left side tumors. For example, there is a growth in the descending colon that is causing obstruction. There you can do a bypass operation. That means you can anastomose the transverse colon to the sigmoid colon. If the patient is very sick, is very unfit, even for the anastomosis, you just bring out the transverse colon outside and do the transverse colostomy. So there also you can do the anastomosis, no problem. You can do the anastomosis between the transverse colon and pelvic colon. the side-to-side anastomosis, okay, I could understand your doubts. You are telling that anastomosis will give leak in unprepared bowel. And why are you doing anastomosis? That must be your doubt in your mind. I got it now. So iliotransverse colostomy or transverse and pelvic colon anastomosis, these two things are done side to side. Side of the ileum to the side of the transverse colon. You are not resecting or cutting the bowel across. If you do hemicolectomy, either left or right, what you do? You cut the ends. So the ends will be there. So the ends are anastomos. Or else you can suture the ends and do the side-to-side anastomosis. But these ends, they are very dangerous. In unprepared bowel, these ends of the bowels, they will give the leak. So you avoid cutting the bowel and then cutting the end of the bowel. So to get the cut end, if it is anastomosed or sutured, it gives a problem. But if you do just side-to-side bypass, you are doing through the serous coat and you are doing the anastomosis through the tinea coli. End-to-end anastomosis, where are you doing? The all-coat suture, you are taking only the circular coat. The longitudinal coat is there only at 3 places. At other places, there is no longitudinal coat. That is why the anastomosis cannot be a perfect anastomosis. Suturing also cannot be a perfect suturing because the all-coat suture doesn't have the total longitudinal coat. And the circular coat is stretched in case of obstruction. So a stretched circular coat, when it is sutured, it will not take the bites well. It will cut through. Or post-operatively, it may leak. But when you do side-to-side anastomosis, the side-to-side anastomosis, though it is an anastomosis, it doesn't leak. Why? Because you are doing the anastomosis through the place of tinea coli. So when you cut the tinea coli and suture the tinea coli site, so you are taking the bite through full thickness of the muscle. Because there is longitudinal coat, circular coat, submucous coat, mucosa. Everything is there and along again serous coat. So when all the 4 coats are there, when you suture them together, then it will be a pakka anastomosis. But when you do it to the ends, end-to-end anastomosis, then it is always fraught with a lot of dangers of leakage because longitudinal coat is not available throughout the circumference. Even if you want to do side-to-side anastomosis in those cases, what you should do? You should first close the end of the stump. Then you do side-to-side anastomosis. So when you close the end of the stump, that particular part again may leak because the longitudinal coat is not there uniformly. Now, am I clear in clearing your doubts? Okay, that is why you are always telling ileostomy and colostomy like that. Because I said that anastomosis is fraught with peril of leakage in acute unprepared bowel. So you are always telling that why to tell anastomosis? We should tell colostomy or ileostomy. That is why you are answering that. I could get your point there. You can do it, but you can do a bypass anastomosis also. The anastomosis should be done through the place of tinea coli. Then there is no harm. I hope I am clear. Okay. So on the right side, you can do iliotransverse colostomy. On the left side, you can do the transverse colon pelvic anastomosis, pelvic colon anastomosis. That is transverse pelvic colostomy. You can do it without any problem. Okay, that's fine. Now I'll go to the next slide. That is the adynamic obstruction. So when you have doubts like that, please express it boldly, openly. I don't feel anything. I will explain till your doubt is clear. That only gives a satisfaction to the teacher. If I can clear your doubts, if your mind is now very free to receive everything without any fog, then you can understand this subject well. Okay, that's nice. You have expressed your doubt very much. Nice of you. Okay. Now let's go to the next topic. That is adynamic obstruction. Adynamic obstruction can be due to paralytic ileus or pseudo obstruction. And third one is due to mesenteric vascular insufficiency. Paralytic ileus definition: failure of transmission of peristaltic waves secondary to neuromuscular failure, that is myenteric plexus and Meissner's plexus. So this plexus fails. Either it may be physiological, it is most of the times it is physiological failure of the transmission in the enteric nervous system. The enteric nervous system stops functioning for a while. So then what happens? There is no peristaltic activity. So whenever there is no peristaltic activity, there will be accumulation of fluid and gas within the bowel. So that causes the third space loss. This produces dehydration and shock, as well as abdominal distension. The types of paralytic ileus being: number one, postoperative paralytic ileus. This postoperative paralytic ileus can occur after any abdominal procedure. So once you open the abdomen and close the abdomen, the bowels will go into paresis. Already I told you, even a slight touch or stretch can cause the bowels enteric nervous system to have functional blockade for few minutes or few hours. That depends upon the amount of stretch. If the stretch is mild, that means if you just hold it and leave it, it will be there for 2 or 3 hours. If you hold it and then do complete exploration or little stretching is there, so that will give the paresis for about 2 days. If there is a rough handling, if the bowels are pulled this way or that way, retracted, lot of mops are kept and they have been retracted, they are pushed. So if there is a lot of stretch on the mesentery or on the bowels, then there will be paralytic ileus for more than 5 days. So it is a self-limiting and variable duration. So that depends upon the amount of insult that has borne by the bowels during surgery. They are prolonged. The paralytic ileus is prolonged in the presence of hypoproteinemia or metabolic abnormality. So metabolic abnormality means usually potassium. Hypo or hyperkalemia will cause paralytic ileus. The next cause of paralytic ileus is because of infection, localized or generalized ileus, depending upon localized or generalized peritonitis. So whenever there is peritonitis, the bowels which are adjacent to that inflamed peritoneum will be having paralytic ileus. Why should there be paralytic ileus in case of peritonitis? Just imagine and tell me. Why? What is the need? Is there any functional benefit, or just like that the bowels will undergo paresis in peritonitis? For example, there is appendicitis. There is localized peritonitis in the right iliac fossa. So there will be paresis of the bowels in the right iliac fossa. Rest of the bowels, they are moving. But bowels in the right iliac fossa, namely the cecum, the ileum, they are not moving. Can you tell me why? Wonderful, Fatima. You are excellent. You said an excellent answer. By paralytic ileus, the spread of infection is limited. If the bowels are moving, suppose, what happens? The inflamed exudates will be there on their surface. So when they move, when the peristalsis is there, this inflammatory X-ray also is propagated on the peristaltic activity. So when the bowels move, the X-rays also move. So a localized peritonitis will become generalized peritonitis. To prevent that spread, so nature has provided this mechanism of periodic ileus. It's not for the sake of pain. It is only for prevention of transmission of infection to the other parts of the peritoneal cavity. For that reason, there is ileus. Then third type of reflex ileus is called the reflex ileus. This occurs following fractures of the spine or the ribs. So whenever there is fracture of the spine or the ribs, so because of the severe pain and bleeding in the retroperitoneum, the patients will have the periodic ileus. So this will be there again for the retroperitoneal hemorrhages, application of a plaster jacket. Then metabolic factors like hypo and hyperkalemia. Urea means it is again hyperkalemia. Clinical features of periodic ileus: bowel sounds and pain are absent. So there is lack of transit. So because there is lack of transit, what will happen? There will be abdominal distension and there will be vomiting. The vomiting is not projectile type because there is no reverse peristalsis. In case of dynamic obstruction, whenever there is obstruction, the bowels try to overcome the obstruction. The bowels fail to overcome the obstruction, there will be again a retropulsion activity. This retropulsion activity will cause a projectile vomiting. But in periodic ileus, the projectile vomitings are not there. Just the patient gets mouthfuls of fluid into his mouth and he spits it out. It is not a projection type of vomiting. There's a bowel sounds and pain, both are absent. Flatus is not passed. The fractures cause periodic ileus because of severe local pain. The ribs from 7 to 12, they are all thoracic nerves. So when they are fractured, that produces a lot of pain over those dermatomes. The bowels are also innervated from T7 to T12 and L1 and L2. So whenever the lower ribs are fractured, that can cause an efferent impulse in the system, and the brain will think that those impulses are coming from the bowels, because efferent impulses coming from T7 to T12 will be decoded by the brain as coming from the bowels. So reflexively, the bowels will undergo paresis. That is how the bowels undergo periodic ileus in case of fractures. This occurs usually in the lower ribs, not in the upper ribs. Since periodic ileus flatus is not passed, there will be copious nasogastric aspirate or copious effortless vomiting, abdominal distension, which is tympanic. Periodic ileus should be suspected in the postoperative period after 72 hours if any of the above are present. Investigations: plain X-ray abdomen. There will be multiple air fluid levels. So by looking at the plain X-ray abdomen, you can't differentiate whether dynamic or adynamic obstruction. In periodic ileus, there will be multiple fluid air levels. Then estimation of potassium. Then in case of postoperative case, whenever the periodic ileus is there more than 3 days, you must always look for anastomotic leak by appropriate investigations. Management: prevention. During surgery, the bowel should be handled gently. The peritoneal cavity should be free from blood clots before closure. So before closing, if any blood clots are there or blood is there in the peritoneal cavity, it should be washed free of clots and free of blood. Similarly, when you are doing anastomosis in the intestine, sometimes intestinal juices may leak out. So then you must do a peritoneal toilet, that means peritoneal wash, before closing the abdomen. So no irritant material should be left behind in the abdominal cavity before closure. In the postoperative period, nasogastric suction and restriction of oral intake is advised until return of bowel sounds and passage of flatus. Because there is paralytic ileus, the bowels are not moving. So there will be retention of secretions in the stomach. So what best you can do is you put a Rayleigh tube and aspirate the contents till the bowel sounds appear. Once the bowel sounds appear, what happens? The patient passes flatus. The nasogastric aspiration all completely decreases. Then patient can be advised to take oral fluids. Then food. That is why in all the postoperative cases on the abdomen, you don't advise the patient to take food or fluid by mouth immediately because of paralytic ileus. Till the paralytic ileus subsides, that means 48 to 72 hours, you keep nasogastric aspiration and IV fluid administration, and advise the patient not to take anything by mouth, because even if he takes anything by mouth, it is not going to get absorbed. Maintenance of electrolytes. Considered management, this is management of the cause and dip and suction. Dip and suction means, dip means intravenous fluids, suction means nasogastric aspiration. There is no place for peristaltic stimulants. In prolonged cases, look for anastomotic leak or for collections in the peritoneal cavity. In resistant cases, organic obstruction should be excluded, and if in doubt, laparotomy is done. So if the patient should respond for your treatment within 2 days or 3 days. If not, means there may be anastomotic leak or there may be collections in the peritoneal cavity. That's why you must do a ultrasound scan. If any doubt is there, you must go for CT scan. So when you do CT scan, then you will be able to identify collections as well as any leakage from the anastomotic site. So you must again reoperate and then close the anastomosis again. In some cases, there may be an organic associated obstruction. So if paralytic ileus is not getting relieved, then what you must do is you must open the abdomen and explore for any organic obstruction. Pseudo obstruction. Obstruction usually of the colon due to neuropathy or myopathy in the absence of a mechanical cause. It is just something like paralytic ileus. But paralytic ileus usually affects the whole of the gut, and mostly the small bowel is affected. Colon is also affected but not much distended. But in pseudo obstruction, colon is grossly distended. In paralytic ileus, the whole bowel is paretic, and in pseudo obstruction, the proximal normal bowel shows features of dynamic obstruction. That means if there is colonic pseudo obstruction, that means colon is not moving. Why? Because of the neural problem or because of the muscular problem. That is due to myopathy or due to neuropathy, the colon peristaltic activity is absent. So whenever this colonic movement is absent, then what happens? The small bowel tries to overcome the obstruction by vigorous peristaltic activity. So in pseudo obstruction, one part of the bowel, if it is undergoing functional paresis, the proximal part of the bowel will be undergoing vigorous peristalsis, and it behaves like a dynamic obstruction. In dynamic obstruction, what is happening? There is vigorous peristaltic activity. If the obstruction is relieved, it's okay. Otherwise, there will be reverse peristalsis with projectile vomiting. So in this case also, there will be colicky pain. In paralytic ileus, there is no colic because there is no peristaltic activity. The bowels are atonic and dilated. So there is constant dull ache pain in paralytic ileus. In pseudo obstruction, one part of the bowel is dilated and atonic. The proximal part of the bowel is undergoing hyperperistaltic activity and causes severe colicky pain. After any anastomosis, for the paralytic ileus to get normal activity, it takes about 48 to 72 hours. Either after laparotomy, even after anastomosis, also the same thing. So you wait for 48 to 70 hours. When the bowel sounds reappear, you can ask the patient to have fluids by mouth. So there is a difference between perotic ileus and pseudo-obstruction. In perotic ileus, the whole of the gut is perotic. In pseudo-obstruction, one part of the bowel only is affected with functional paresis. The proximal part is responding by vigorous hyperperistaltic activity. Causes of pseudo-obstruction: idiopathic, metabolic, that is due to diabetes mellitus. You know diabetes neuropathy and diabetic myopathy. So usually in diabetes mellitus, the colon is very much affected. So most of the patients of diabetes mellitus, they have constipation. Similarly with myxedema, because of reduced metabolic activity, so there is reduced functionality of the bowel movement. Uremia following severe trauma, then shock and sepsemia, retroperitoneal collections of blood, urine, and enzymes. So in all these conditions, the neural elements dominate. So we have seen that the motility of the bowel is dependent upon three factors. What are they? What are the three factors responsible for motility of the bowel? What are the three factors responsible for motility of the bowel? The three factors responsible for the motility of the bowel being enteric nervous system, number 2, the autonomic nervous system, number 3, the neuropeptide hormones secreted by the gut. These three are responsible for bowel movement. The migratory motor complex, MMC, is a type of motility activity. So it is not a factor for causing motility. I am asking about the factors which cause motility of the gut. So the autonomic nervous system, the enteric nervous system, and the neuropeptide hormones. So all of them act in synchrony and they cause motility of the guts. So if any of these being affected, then there will be lack of motility. So in diabetics, there is neuropathy involving the autonomic nervous system, as well as the myopathy involving the smooth muscles of the guts. In myxedema, it is a myopathy. Uremia, again, it is the hyperkalemia is acting upon the enteric nervous system and the muscles, because neuromuscular transmission is one of the factors responsible for that is potassium concentration, adequate potassium concentration. Severe trauma, shock, and sepsemia, they will affect the autonomic nervous system. Retroperitoneal collections of blood, urine, and enzymes, they also affect the autonomic nervous system. Then gastrointestinal involvement by certain diseases like scleroderma, Chagas disease, they affect the muscle coats and that causes impaired motility. Then drugs like tricyclic antidepressants, phenothiazines, levodopa, laxatives, they also act on the bowel movement. Sometimes there may be small intestinal pseudo-obstruction. So one segment of the small bowel will be having lack of movement, and the proximal part of the bowel will be having hyperperistaltic colicky movements. There will be recurrent subacute obstruction. The diagnosis is made by exclusion of a mechanical cause, and most of these cases they require laparotomy. Treatment: treat the cause. If there is no cause, you can give prokinetic drugs like cisapride, domperidone, metoclopramide. Erythromycin antibiotic is also a prokinetic for the gut. Colonic pseudo-obstruction is more common. Types of manifestations: acute, that is called Ogilvie syndrome; chronic. Clinical picture and plain X-ray features are similar to chronic dynamic obstruction. So in dynamic obstruction, what will happen? There is constipation. That is first feature. Next, there is distension. Next, there is pain in the lower abdomen. Vomiting is not a feature. So same things will be there in pseudo-obstruction also. If you take plain X-ray of the abdomen, you will see dilated gas. It's a dilated colon with gas shadows. Then what you do in case of dynamic obstruction? The patient has come to you with constipation, peripheral abdominal distension, and colicky pain in the hypogastric region for the past 1 month or 2 months. So whenever there is constipation, initially relative, later absolute for 1 or 2 days, so the patient has come to you, then what you do? Clinically, you do the examination, abdominal examination. Then you do distal examination. There is no mass in the rectum. Then what you do? What investigation you do? Before giving barium enema, what you do? You do plain X-ray abdomen. Plain X-ray abdomen will show whether there are any gas shadows in the large bowel, small bowel, etc. So X-ray of the large bowel will show you dilated colonic shadows. So whenever colon shadow is there, means it is colonic obstruction. So then what you do? Then you go for barium enema. So initially you do only X-ray of the plain X-ray of the abdomen. It is not erect film. You better take supine film or both. Supine will show you the gas shadows. Erect will show you the air fluid levels. In colonic obstruction, the air fluid levels are less. They are not frequently seen because the fluid is absorbed by the guts. Mostly it is air-filled bowel, and there is a lot of solid fecal matter, not the fluid fecal matter in the large intestine. That is why you don't see air fluid levels in case of colonic obstruction. That is why erect picture is of not much use. You have to go for supine film, which will show you the gas shadows. If the colon is showing gas shadows, that means that it is a colonic obstruction. The obstruction can be either organic obstruction or it can be pseudo-obstruction. So next thing what you do, you give barium enema. If there is an organic obstruction, it is shown as a filling defect. If it is a functional obstruction, the whole colon is seen normally without any filling defects. So that is what you do. So colonic obstruction, pseudo-obstruction, clinical and plain X-ray features are similar to the chronic dynamic obstruction. Investigation: colonoscopy or water-soluble contrast enema. You can do barium enema also, or you can give, preferably, you can go for a water-soluble contrast enema. So water-soluble contrast enema will tell you whether it is an organic obstruction or a functional obstruction. Treatment: treat the cause if detected. That means if metabolic cause is there, you detect it, you correct it. Otherwise, you give neostigmine 1 milligram IV and repeated if the first dose is ineffective. So what you are doing? You are doing parasympathetic stimulation, because we have already seen that bowel is under the control of autonomic nervous system, Autonomic nervous system, the motility is under control of parasympathetics. So you are giving a parasympathetic stimulant, that is neostigmine. So give neostigmine 1 milligram IV and repeated if the first dose is ineffective. This should be done under ECG monitoring, because whenever you are giving neostigmine means you are giving parasympathetic activity to the body. So what is the parasympathetic activity to the heart? This cardiodepressant. So there will be bradycardia with decreased cardiac outputs. That is why you must be alert with ECG monitoring to see for any changes in the heart. And atropine should be available. If you notice any of the side effects in the ECG, immediately you must administer atropine. You can try cisapride. If they're not functioning, then you can go for colonoscopic decompression. That means you pass a colonoscope and then you aspirate all the air from the colon. When colonoscopy fails or unavailable, you can do a tube cecostomy. You can, because we've already seen whenever colon dilates, cecum is the one which bears the brunt. It dilates to the maximum and it is the first one to undergo gangrene. So what you do is you do a tube cecostomy, drain the cecum. With impending perforation of the cecum, that means when cecal diameter is more than 14 centimeters, surgery is advocated. Surgery is subtotal colectomy with ileorectal anastomosis. This is how you manage the pseudo obstruction of the colon. Any doubts, please? If there are no doubts, we will proceed to the next topic, that is the mesenteric ischemia. This also causes intestinal paresis. So not only the neuronal involvement, sometimes even the vascular impairment also causes the paresis. So acute mesenteric ischemia. Classification: acute with or without venous occlusion. Then chronic vascular occlusion. Chronic vascular occlusion of gut vessels can be central or peripheral. It may be due to obstruction of the superior mesenteric vessels, due to embolism, thrombosis, inferior mesenteric artery occlusion. It is usually silent due to owing to a better collateral circulation. This is only to just to recapitulate the vascular anatomy of the bowels. This is the abdominal aorta. This is superior mesenteric artery, and from the left side of superior mesenteric artery there will be multiple vessels, jejunal and ileal branches. Those are not shown here. So they go to the small bowel. Then for the large bowel, ileocolic, right colic, middle colic. This is for the midgut. Then inferior mesenteric artery is the artery of the hindgut. It gives of the left colic, then sigmoid vessels. It continues down at the superior rectal artery. There is an anastomosis between all these arcades in the concavity of the colon. And these arterial arcades, they join together, they are called as the marginal artery of Drummond. Marginal artery of Drummond. The sources for the embolism of the blood vessels: left atrium associated with fibrillation, a mural myocardial infarct, Ethermann's plaque, aortic aneurysm, and a mitral valve vegetation associated with endocarditis. The sources for thrombosis being atherosclerosis, thromboangitis obliterans, contraceptive pills, sickle cell disease, and primary thrombosis of superior mesenteric veins. That means idiopathic thrombosis of superior mesenteric veins. The cause is not known. Sometimes there will be superior mesenteric vein thrombosis. That is due to some coagulation problem. So what happens when there is occlusion? It depends upon the site of the occlusion, main vessel or a branch, and associated venous involvement. The main vessel superior mesenteric artery is involved. The infarction or the gangrene extends from just 1 minute. The main vessel of the superior mesenteric artery is involved. The gangrene extends from just distal to the duodenal flexure to the splenic flexure or terminal ileum, depending upon the marginal artery presence. Now, this is the marginal artery. The marginal artery is formed by branches of the superior mesenteric artery and inferior mesenteric artery. So, where is the joint? Here, this is the place where both of them join together. Sometimes they do not join here. Then this point is called the critical point of Sudeck. So if there is no anastomosis between the superior mesenteric artery branches and inferior mesenteric artery branches, then what happens? If superior mesenteric artery is blocked, what will happen? The superior mesenteric artery is blocked, then the blood from inferior mesenteric side is not coming here. So up to splenic flexure, the colon becomes gangrenous, and whole of the ileum and lower part of the jejunum undergoes gangrene. But the proximal part of the jejunum will be viable. Why? Because there is an alternate collateral supply from gastroduodenal artery. We have seen already gastroduodenal artery dividing into right gastroepiploic and superior pancreaticoduodenal artery. The superior pancreaticoduodenal artery anastomosis with inferior pancreaticoduodenal artery. Inferior pancreaticoduodenal artery is a branch of superior mesenteric artery. So when superior mesenteric artery origin is blocked, then the blood flow from gastroduodenal artery into the superior pancreaticoduodenal artery, from there into the inferior pancreaticoduodenal artery, from there to the anastomotic branches into the superior mesenteric blood vessels. So there are arterial arcades are there. Through these arterial arcades, the proximal part of the jejunum will survive. The distal part of the jejunum, ileum, and the colon developed from the midgut will become gangrenous. If this marginal artery is patent, if there is no block in the anastomosis, if it is completely through and through is there, then the blood from inferior mesenteric artery will flow through the marginal artery and colon will survive. And terminal ileum also will survive. So a short segment of bowel, this part of the bowel will undergo gangrene. So marginal artery is present in most of the patients. The anastomosis is absent only in very few patients. That is why in majority of the patients with superior mesenteric vascular occlusion, only a small segment of ileum and jejunum is affected. If only one branch of superior mesenteric artery is involved with thrombosis, then the area of infarction is less. Blood-stained fluid exudes into the peritoneal cavity and into the bowel lumen of the infarcted bowel. So whenever there is gangrene, there is oozing of blood into the lumen of the bowel, outside the bowel wall, into the peritoneal cavity. Clinical features: there will be sudden and severe umbilical pain in a patient with atrial fibrillation or atherosclerosis. There is passage of altered blood per rectum. there is hypovolemic shock. Why there is hypovolemic shock in vascular thrombosis? So whenever superior mesenteric artery is blocked, a large segment of vascular flow is stopped. That means the return of blood to the heart also is decreased. That means from the gut, there will be around 1500 to 1600 ml of blood returning to the heart. So when this is blocked, then what happens? There will be fall in the cardiac output by at least 2/5. This is 1 liter means it is almost 1/5 of the total blood volume. So 1/5 to 2/5 of the cardiac output will be decreasing. That is, there will be hypovolemic shock. There is abdominal tenderness with rigidity later due to oozing of blood into the peritoneal cavity. Investigation: total leukocyte count, neutrophils, leukocytes will be there. Plain X-ray abdomen. The presence of gas bubbles in the mesenteric veins is rare but pathognomic sign. So when in doubt, you must always, that means whenever a cardiac condition patient gets severe abdominal pain with shock, you must immediately do superior mesenteric angiogram. Superior mesenteric angiogram will reveal whether superior mesenteric artery is patent or not. So this is a CT angiogram. You can see a thrombus here. Treatment: resuscitation. In early embolic cases, which is rarely diagnosed, embolectomy via the ileocholic artery or revascularization of superior mesenteric artery may be considered. In gangrenous cases, all affected bowels should be resected and followed by total parenteral nutrition, anticoagulants in the postoperative period. In selected cases, small bowel transplantation may be tried. Treatment of large bowel infarction, it is rare. Presents with gangrene, resection, anastomosis, or colostomy is done. So safe procedure is to do colostomy and resection. Ischemic colitis means it is chronic vascular insufficiency of the colon. This is common in splenic flexure. This may manifest as gangrenous, stricturing type, or transient type. Clinical features: lower abdominal pain and passage of blood per rectum. So this is the chronic ischemia of the colon. So with this, we are going to complete the topic of intestinal obstruction. Any doubts? Okay. If you have no more doubts, I will close this session. Ischemic colitis is treated by evaluating by angiogram. First of all, you must do superior mesenteric and inferior mesenteric angiogram. And where the block is there, that block should be removed. That means, for example, if a atherosclerotic patch is there, you must do a bypass operation. A bypass to bypass the occluded area. That means you must get the normal perfusion. If it is not possible, you must get some vessel nearby and anastomosis to the inferior mesenteric artery, distal to the obstruction. That means that is called revascularization. So when you do revascularization or you do bypass, then this condition can be corrected. Just like treating the ischemic heart disease, any ischemic disease of any part of the body, first you try medical treatment with anticoagulants. If it is not responding, go for surgical treatment. Surgical treatment can be insertion of a stent or bypass operation. If bypass operation is not feasible, you try to do a revascularization operation. Okay. If you have no more doubts, I will close this session, and tomorrow we will have the topic of disease of the rectum and anal canal. So the program will be uploaded on the website either today night or tomorrow morning. You can go through the website and you can register. Thank you, one and all, for being with me, class. Meet you again tomorrow at 4 p.m. Wish you all good night. Thank you and bye.